So welcome and thank you everybody for attending Dignity Health's Doc Talk on New Year, New Needs. These are educational opportunities for you, the community, to meet and hear from industry experts here in your own hometown. These experts are board certified in their specialty and are here to help educate you on the latest techniques and technology offered here in Bakersfield, and to also give you tips on how to stay healthy. We hope that you will join us on March 1st at noon as Dr. Malilari, a board-certified colorectal specialist, will speak to you on colorectal cancer awareness with a patient testimonial. You will not want to miss this as it hits home on the value of screenings. Also in March, we will have a urologist speak as it is National Kidney Health Month. So look for more information on Eventbrite or simply place your email in the chat and we will send you an invite. So now I would like to present Dr. Karl Balch with Southern California Orthopedic Institute and his presentation on New Year, New Needs.
All right, great. Well, thank you everyone so much for joining us here today. I'll have some slides and talk about a bunch of different things. And then at the end of the talk here, I'll make sure we have time for questions. I had a couple questions that were emailed to the event organizers, and I'll try to touch on those first. And then we'll get to any other questions that folks may have around that time as well. So New Year, New Knees. One, two, come on over here. So before we get started, just a little bit about who I am. I'm Karl Balch. I was born in San Diego here in California. Did my undergraduate degree at USC, where I met my wife. I did my medical school at the University of Chicago, my residency at Ohio State. And then I did a specialization in hip and knee replacement at Medical College of Virginia, VCU. I have my CV available on Doximity if you wanted to see about some of my research qualifications and some of the different research projects and things I've been involved with over the years. And I practice, as Stephanie said there, at Southern California Orthopedic Institute, which I have a nice little picture of right there. So just personally about me, I'm married with 2 kids. My daughter is 8 and my son is 5. We moved to Bakersfield about 5 years ago, and I moved to California here to be closer to my family and practice out here. My wife does accounting and photography and a million other things. And I have a bunch of pictures here. I had to update my pictures. I have some slides in here that are some old slides and some updated slides. And the picture I have on the bottom left there, this is my son when we moved here to Bakersfield. He's just 1 year old there. And now he's a big guy and hikes up in wind wolves, and you know they're much bigger now. So I got some new pictures into them. So a brief outline on some of the things we'll talk about. We'll go over a couple of these topics here where we talk a little basics about the knee, talk about what arthritis even is, bone health, exercises, different treatments and things, and then a little bit about some of the surgeries that I do in joint replacement as well. So some of the basic knee anatomy, the knee really has 3 important bones that are relevant. The femur, which is your thigh bone, the tibia, which is your shin bone, and the patella, which is your kneecap in the front of the knee. And any one of these bones in the joint can cause problems. And for knee doctors, we think about the medial or inside portion of your leg, the lateral or outside portion of your leg, and the patellofemoral or basically kneecap joint. Whenever you hear people talk about cartilage, cartilage is what lines the surface of your joint. So it's kind of like a protective coating that helps things glide smoothly. The meniscus, which you may hear people talk about, is a cushion that protects and stabilizes the cartilage. On the picture we have here, you can see these C-shaped objects that are in the joint there, and those are what the meniscus actually is. Ligaments stabilize the knee. They're like ropes that help provide stability to the knee. People hear a lot about arthritis and they want to know, well, what even is arthritis? Arthritis is a really common source of pain for huge numbers of people across the United States. Some estimates have put it at 50 million or more. The most common form of arthritis is involved with a breakdown of cartilage in a joint. So this smooth lining of the joint, this smooth coating starts to get cracks and break down. And then the bones don't have that protective coating and they're not able to move as smoothly. As the cartilage in the knee joint becomes really a lot rougher and broken down much more, it starts to function poorly. It starts to have potholes in it. And just like when you drive on the road, if there's a pothole and things, you can't drive really smoothly, you kind of move back and forth and have bumps and hitches. That has a lot to do with the grinding and bumps and hitches people feel as they move their knee around. Cartilage has very little ability to repair itself once it's damaged. So in general, as people get older, they accumulate more and more damage in their cartilage. Motion causes the bones to grind together when you have this arthritis and damaged cartilage surface. Your body responds to this grinding by producing chemicals that create inflammation and a pain sensation inside the joint. When people talk about inflammation, it's basically just a signal from your body that something is damaged, and that produces the swelling and pain that people get inside their joints. This is what knee arthritis actually looks like on an X-ray. So once the cartilage that we talked about is worn out, you start to see the bones actually touching each other on the X-ray. This X-ray on the right on your screen here is a perfect example of what we call bone-on-bone arthritis. So when you hear someone say, oh, the doctor told me my arthritis is bone on bone. For that to be true, you have to have an X-ray that kind of looks like this X-ray on the right, where you see the bones touching on the X-ray. X-rays only show you bones. You can't see cartilage on an X-ray. So because of that, good cartilage is supposed to be invisible. So this left X-ray of a knee shows space between the joint. That means there is still good cartilage there. And this X-ray on the right shows no space. So no space is no good. That means the cartilage is all gone. I joke with my patients, I tell them cartilage is like tread on a tire. Your tires never get less worn out. Your knee never gets less worn out. It either kind of stays the same of how it is, or it wears out more over time and you get more and more wear and tear that builds up. I tell folks, I say, people can progress their arthritis at different rates, just like people wear out their tires at different rates. It depends on the car you drive, how you drive it, what kind of tires you have, those sorts of things. Same thing with the knee, how quickly people wear them out depends, but everybody ends up in the same place as long as you keep driving or wearing out your knees long enough. So that's really what we're looking at when I'm evaluating a knee in the clinic there. So common question is, what can people do to improve bone and knee health? And lifestyle and exercise is a great place to start. Basically trying to be more active, trying to stay active and be exercising to keep your muscles strong is really important. So that is something where keeping your muscles strong and trying to do more is a good thing. People ask, well, with bad arthritis or bad joints, what are different types of exercises I can do, or what sort of exercises tend to be the best? Swimming is actually the absolute best one because it gives you resistance, uses good cardio, but puts really low impact on your joints because the water supports your joints. Obviously, not everybody has access to a pool, and sometimes, like the winter time, outdoor pools are very cold, so not easy to swim. But in general, swimming tends to be one of the easiest activities. That's really good workout and really easy on different arthritic joints. Biking is something I love, low impact, but also great exercise for your heart, cardio, muscles, but not the repetitive impact inside the joint like you would get with running or jogging. I like to bike myself, and I think it's a great exercise. If you're in a gym where they have exercise equipment, the elliptical, like the lady on the bottom left here is doing, that ski kind of machine, same thing, great workout, but not a lot of impact on the joints, which is great. I also tell people walking, light hiking, things like that are also good. So these are my top 4. These are the most recommended exercises for people with arthritic knees or arthritic joints in general. Weight loss and diet. One of the questions we had emailed to us or messaged to us was asking about, weight gain and arthritis and what's the relationship there. Basically, the way the human body is set up, your joints are loaded based on how much you weigh. So the more you weigh, it amplifies your weight at your knee joint. It can be, depending on what type of activities you're doing, when you're just standing or walking around, it can be, 2 to 3 times your body weight. If you're doing something more intensive, like climbing up stairs or climbing a ladder, people can get to 8 to 9 times their body weight. So it very rapidly can be, up a lot higher. So because of that, people who keep their weight low, it doesn't put a huge load on the joint, and so it wears out slower. people, the heavier you are, when you try to do activities like, say, climb upstairs or something like that, you just take whatever your body weight is and you multiply it, you amplify it. So that's something where I'll tell patients, I'll say, look, if you lose 10 pounds or 5 pounds, that may not seem like a lot, but because of the amplifying effect it has at your joints, 5 to 10 pounds can be like taking a 50-pound barbell off of your knee. So people may think, oh, well, I try to lose weight. I only could lose a couple pounds. Even a couple pounds like that can make a really big impact. And good nutrition is an important part of that. So I always counsel my patients and talk to them a lot about, the best way to be looking at your nutrition is by trying to eat more of the things that are going to be, lower calorie or better for you, more vegetables. After that would be protein, and then carbs would be last. So, things, bread and things like that. I say, you don't necessarily have to stop eating everything that's good, but you just have to eat portions that are a little more reasonable, and you have to change the mix. The traditional mix for something is, well, maybe a little bit of meat, a little bit of vegetables, and then like a lot of mashed potatoes or something. That should be flipped around. It should be a lot of vegetables, a medium amount of meat, and then a small amount of the carbs like mashed potatoes or bread or anything like that. So really, it should be about both picking the portions and also what you're eating. Vitamin D and calcium are really important. Those are really important for bone health. Calcium to make sure you have enough calcium to be going in your bones. And vitamin D is an important part of being able to actually absorb calcium. So especially in the wintertime when people aren't getting as much sunlight, that vitamin D can be really important. Tobacco and alcohol are bad for bone health and strength. So, little drink here and there or anything like that is fine, but people who are frequently smoking and drinking a lot, that does provide some damage and cause problems for your joints as well. So we always recommend against, being in excess on that. When to come see a specialist like me, if you feel your joints are affecting your quality of life, you can't do the things you want to do, your activities of daily living, the things you need to do day to day are getting harder and harder to do. And the last one I put on there is just any time. If you had questions and you just wanted to see an expert or pick the brain of somebody who specializes in things with the joints, then, that's a reasonable thing as well. So talk a little bit about some of the treatments. What can people do that does not involve surgery? And that's always where we start when I see people in clinic and start coming up with a treatment plan. And I listed some of the things on here. Medications, anti-inflammatories or NSAIDs, non-steroidal anti-inflammatory medications, is typically where we'll start. And those type of medications are the common ones that you'll hear over the counter, like ibuprofen, Aleve, these are kind of the mainstay. Now there's prescription versions of these that only I can prescribe. There's topicals like diclofenac or Voltaren gel, which is now available over the counter, which is great. I really like that medication. And another thing about these kind of medications is when you take them, you want to make sure you're taking them correctly to be getting the maximum benefit. So I'll sometimes have patients that say, oh, I've had a lot of pain. I tried some ibuprofen and it didn't help much. And I'll say, okay, well, how did you take your ibuprofen? What did you do? All right, well, I took one pill in the morning and then I was having pain, later in the day when I was walking around. Well, one pill of ibuprofen, most of the over-the-counter ibuprofen is 200 milligrams, and you can take up to an 800 milligram dose. So a single pill isn't necessarily a very strong dose of that. And within a couple hours, ibuprofen is out of your system. Ibuprofen does not last very long. So often what I like to do for patients is get them on medications that last a little longer, like naproxen or meloxicam. Those are once or twice a day dosing, so you only have to take 1 or 2 pills. Ibuprofen, to really have strong, long-lasting efficacy of ibuprofen, you have to be taking it every 6 hours essentially, which people do, and some people really like ibuprofen, but obviously it's more work or harder to be frequently taking a medication throughout the day. And that's really the way it works the best. So for people who are kind of looking at, well, I tried the medicine, it didn't work, I'll often look and see, well, how much were you taking, what dose, how frequently? All of those things have a big impact on how effective it may be. Physical therapy can be very helpful. Strengthening stability of your knee lowers the forces that go across your joint, reduces injury. Some people will say, well, is going to therapy going to make my arthritis go away? And the answer to that is obviously no. But the stronger you are, the better you're able to compensate for arthritis in your knee, the more functional you are. I tell people therapy and exercise is about making the best of a bad knee. So it doesn't necessarily magically fix your knee, but the stronger you are, the more you can do, the better it is. Injections are some of the strongest non-surgical treatments we can do, and I do lots of different types of injections in my clinic. There are steroid injections. Traditional steroids, people will put in there as a powerful anti-inflammatory. Within the past couple of years, they've developed longer acting steroids. So we have a new type of steroid that basically is released over time into the knee, and that's something that's very new and can have a longer lasting effect. We do lubricating injections as well, which are basically gel, kind of WD-40 for your knee, where we put that in there to try to lubricate things and get them moving better. And there's been a lot of research looking at biologic or regenerative type of injections, and that's still very much in a kind of a research category. Those type of injections are not typically covered by any kind of insurance or anything like that. So I try not to do a whole lot of that kind of stuff just to be keeping costs down for my patients. But patients often have questions about, stem cells, PRP, other types of regenerative or biologic injections. And I do have the capacity to do some of that for people who are interested and talk a lot about what the current state of the art and what the research says about that. These injections are generally the most powerful non-surgical things, so I will do a lot of those. Braces can be very helpful. They're really good for stability. I usually talk to patients about, what brace, and I talk to them about what their goals are and what they're trying to do. And so I talk about what types of braces may be best, what are over-the-counter options that may be, cheaper, more affordable, that are really helpful for bracing versus different prescription types of braces, and how I like to use a brace best. In general, for me, the thing I think is most helpful for a brace is to occasionally use a brace. I don't like wearing braces all the time, essentially, unless somebody had a recent injury. So if somebody has a recent injury, okay, maybe you wear a brace all the time for a couple of weeks while you recover from the injury, and thereafter you start to work your way back out of the brace. But the way a brace really shines is when you wear the brace when you're doing something that may be a more vigorous activity, but not wearing it, 24 hours a day and all the time. Because if you wear a brace all the time, essentially your muscles get weaker because they're used to having that brace supporting them. And then it's like you're not even wearing it because the muscles just kind of atrophy and you lose it. If you only wear it when you're, say, going for a long walk or doing something that's more physically demanding, it gives you the extra support when you need it. And the rest of the time, you don't lose the muscle from using it all the time. People ask me in clinic all the time, when's the right time to have surgery for a knee? I like to try the non-surgical stuff first, obviously. If non-operative treatment is not changing kind of the mechanical problems that people are having, surgery really is the only thing that can do that. From my perspective, there's never a rush to have surgery. I like people to feel like, they've tried some of the other stuff, it's not working, and it's really limiting, their pain and function throughout the day. So in terms of surgery, what is the surgery for arthritis, or what are some of the different knee surgeries? For meniscus and things like that, there's arthroscopic surgeries. For cartilage damage and arthritis, I do joint replacement. And there's two categories of joint replacement for the knee. There's the total knee replacement, like you see on the left. In the total knee replacement, you redo all of the major sections of the knee. So in the beginning of the talk, when we talked about femur, tibia, patella, total knee replacement redoes everything. And it redoes all of those surfaces, medial, lateral, patellofemoral. Every single surface of cartilage is replaced with artificial parts. So that's the complete redo. I also have the option of doing unicompartmental or partial knee replacement, which you can see on the right picture here. And that's basically where we do a much smaller surgery where you only do one section of the knee. So in partial knee replacement, just like this x-ray shows, you can see somebody where with good joint space on the outside of the knee over here, but it's bone on the inside. Patient may tell me all of their pain is on the inside of the knee, and we have this x-ray that looks otherwise pristine. In that case, I can just do part of the knee. So I just do the partial replacement on one side, just like these diagrams show. That's a much smaller surgery, faster recovery. Faster recovery can be done as an outpatient. A lot of benefits to doing that. But in people where they have arthritis on both sides, that's obviously not an option. So everybody is not a candidate for a partial, but people who are, it's worth considering as a less invasive, smaller surgery option. Total knee replacement is what we talked about, where you redo the entire thing. People, just like in this picture on the right, where you can see the cartilage damage wearing down to bone throughout the knee, replace the whole thing, redo everything. New technology and techniques. There's been a lot of changes in joint replacement over the last 10 to 15 years. Things have evolved quite a bit. Now we're able to do several people's surgeries as an outpatient where they go home same day. Everyone's not a candidate for that, but some people certainly are. And people who tend to be, more physically active and a little better, they can get up and get going same day and get home the same day. You don't need to spend the night in a hospital anymore. And in fact, we're doing a lot of these joint replacements in the surgery center at this point. Improved pain control after surgery. We do nerve blocks, what's called multimodal pain medication, which is where we can do multiple different pain medications. So you're not having to take such high doses of narcotic or opioid pain meds. I do tourniquetless surgery. So I do my knee replacements without the use of a tourniquet, squeezing on the thigh to restrict blood flow. That helps people recover faster and have less pain after the operation and better motion. We also use a medication called TXA, which basically limits how much bleeding people do during the surgery. This has really eliminated the need for blood transfusions when we're doing knee replacements, where when I was a young doctor, we used to, every once in a while, have to give blood transfusions after surgery. It's been years since I've had to give a blood transfusion during a regular knee replacement, and that's even not using a tourniquet. I don't use a tourniquet, and even with Jehovah's Witnesses, where they can't get blood transfusions, we just don't need to do that anymore, which is great. I've been using computer-assisted knee balancing technology for many years. That's something where, whether via either sensors that are used during the surgery to give me pressure loads on the knee so I can balance it with greater precision, or now we use a lot of robotics when we do the joint replacement surgery. And I included a picture here of what a robotic system looks like. The robotic system gives me live feedback and information about the balance and alignment on the knee while I'm doing the surgery. So this robotic assisted surgery is relatively, is new technology to Bakersfield, but it's not new technology necessarily. I had done robotic surgery on knees when I was a resident, 11 to 12 plus years ago. We were doing the stuff then, but they just didn't have the systems. We didn't have the robotic systems here in Bakersfield until the last, year or two here. So now with this robotic surgery, we're able to make more accurate cuts, increase the precision during our operation. We have a lot more control over where I want to put the implant. So I have a lot more control over alignment and how to put things. And so for some patients, they have really specific things about their knee that I can do the surgery with greater precision to accommodate their specific knee problem. They're much more accurate in the implant positioning. There's less implants that end up as outliers or in kind of weird positions. And it allows us to use newer implant types. And if anybody has any questions about that, I can talk a little bit about what the difference is between cemented or cementless knees. But the robotics has really opened up some new options for that as well. So that's that's the talk and kind of overview of a lot of the things about the knee. I wanted to make sure to leave plenty of time here to answer questions and talk to folks about anything they may want to know in regards to the knee. Stephanie, I think I'd addressed a little bit about the question about weight gain and arthritis, but just to talk a little bit more about that. Basically, the lower your weight is, the lower the forces are that go across your joint. The heavier you are, the more force goes across your joint, and that does accelerate the arthritis process and increase knee pain. So it's very common for folks to have more knee pain if they're gaining a lot of extra weight. I have certainly had patients where they gained a bunch of weight and were having a lot more knee pain. And we have a certain threshold of weight where we decide whether it's safe or not to proceed with knee replacement surgery. So I've had patients where their weight was over the line, where they were too heavy and they were not a candidate to have a knee replacement. And I talk to them and we come up with a plan of how to lose the weight before they do a surgery. And after they actually lose the weight, all of a sudden their knee doesn't hurt so bad anymore, which is actually a great outcome. I'm always really happy when that happens. So I definitely have people where they've lost some weight in preparation, thinking they needed a surgery, and just the fact of losing the weight actually made their knee feel a lot better. So that's great news. And so weight and weight loss are really important for reducing the progression of arthritis and pain inside the knee joint. And then Stephanie, what was the other question I blanking on that they emailed us on? There was a different question about something.
There was. Hold on for just a second. I will let you know. There was several. You talked about alleviating pain naturally versus analgesics.
That's a great question. So in terms of what are natural ways to alleviate pain inside the knee, there's lots of different options. I talk to patients about different herbal or natural alternatives to traditional medications. In terms of herbal, like supplements, what are the best supplements to help with knee pain? The big three I typically will comment on is turmeric, ginger, and boswellia. And when they've done studies where they looked at hundreds of different naturally occurring anti-inflammatories and compounds, those three are the ones that came out on top. Boswellia, Boswellia, actually is the number one. That's the best one. If you look at a lot of the prepackaged, natural joint pain reliever, whatever kind of stuff you may see online, if you look at the ingredients, what's actually in those things, often they have boswellia, turmeric, or ginger in some different, combination as part of those different supplements. I get a lot of questions from folks where they ask me about hyaluronic acid or osteochondroitin and a lot of those kind of supplements. There's really not great scientific evidence behind those things. They're not harmful. You're not doing anything bad to your knee, but they haven't been shown to have any big effect on knee pain or protecting cartilage or anything like that. The analogy I use for folks is I say, if you eat a slice of pizza, your body doesn't grow a pizza inside your body. It breaks down the pizza. Same thing with the osteochondroitin and things like that. Osteochondroitin is a building block that your body uses to make cartilage, but just because you eat that doesn't mean you grow cartilage inside your body. It means your body breaks it down into the basic building blocks that cartilage is made of. And the basic building blocks of cartilage tend to be basic amino acid, pretty basic stuff that you should have in your diet anyway. Most people eating a traditional Western diet will have those things in their diet anyway, and the osteochondroitin isn't necessarily adding anything very beneficial. The other natural thing people ask about is CBD, which is the cannabinoids or, like a marijuana-based compound. That is actually an anti-inflammatory. So the way that works is it works as an anti-inflammatory as well. And the CBD portion of that, it doesn't make you high like the THC part of marijuana does. So it doesn't have any of the drug effects of marijuana, but it does have anti-inflammatory as part of it. So that is an alternative as well. Some people will get CBD creams and rub those on their knees and things like that. And, that works too. That's fine. So those are some of the best acting natural compounds to help with arthritis pain. So I'm looking on the chat here and I'm seeing a couple questions coming across. I'll try to address those. Is there an age when a knee replacement is too risky? And that's a great question as well. So from my standpoint, there is not an age when a knee replacement is too risky, but I have some caveats to that. What's much more important than your age in relation to your risk of a surgery is what your health status is. And I'll explain what I mean by that. In general, people who are older have more health problems, but that is not always true. That is not always the case. So I have people that may be 80 years old, but they're 80 years old and they're very active and they walk around a lot and they live alone and they still drive. And maybe they have a little blood pressure problem, but in general, they're very healthy besides the fact that they have a terrible knee. Well, that patient's risk for surgery is generally not very high. I also have patients that may be 55 or 60 years old and they have diabetes and they smoke and their heart's bad and they have COPD because of their smoking and their lungs are bad and everything's in really bad shape. Well, the person who's 50 or 60 and has all those medical problems is at significantly higher risk for problems or complications from a surgery compared to the 80-plus-year-old who is otherwise generally very healthy. So it's really much more about your health than your age. Age is just a number. So that's what I always look at when I'm determining risk for surgery. Perfect analogy for that is hip replacements. I do hip replacements as well. I'll have lots of people who may be older and say, well, am I too old to have a hip replacement? Well, if an older patient falls down and breaks their hip, God forbid, and they come into the hospital, we do hip replacements for those people all the time, because what else can we do? They broke their hip. And we have people who are in their 90s who fall down and break their hip and end up getting a hip replacement. So in that case, there's not really another option. And our anesthesiologists do the surgery for them, and I do the surgery for them too. So we're very commonly doing surgery in very old people who may have a lot of medical problems, and there's no other option. So we do that pretty routinely. Obviously, my job and goal as a surgeon is always to minimize risk as much as possible. But those are the factors that we think about when we're trying to make a decision about, what to do next and what the options are. Another question on here: what is the rehab time for a cadaver meniscus replacement? So that's a very interesting question. Cadaver meniscus replacement is fairly uncommon. There's not too many people doing cadaver meniscus replacements. It does exist. There's also artificial meniscus replacements. So there's people who have made an artificial meniscus. In general, the rehab time for those things can be fairly long, depending on the weight bearing status and how they want to progress it. Depending on your age and what other things are going on inside your knee, people who are older will much more commonly, they're better candidates to have replacement surgery or a partial knee replacement surgery as opposed to a cadaver meniscus replacement. If somebody who's really young, if you're 20 years old and your meniscus is fried and you need something to try to buy some time until you get older to have a joint replacement, that's where the meniscus replacements really shine. People whose meniscus is totally trashed and they're really young. For older folks, generally the rehab is faster and easier to do a partial knee replacement if it's just the one side that's damaged. So I do a lot more of that as opposed to cadaver meniscus replacement. But it is a procedure that exists, and in certain candidates, it's a really good procedure. But again, it tends to be a very limited subset of people who are really good candidates for that. Next question on here: how long do the newer implants last for active people? That's a great question. I quote different numbers for people depending on their age a little bit, as well as whether we're talking about partial or total knee replacements. Total knee replacements with the newer technology, the new plastics we have, generally last 15, 20, 25 years, depending on your activity level. The thing that causes them to wear out faster is heavy impact exercise. So when you run or jog, the inside of your knee smashes down every step you take. Boom, boom, boom. It kind of hits like that. That causes things to wear out much faster. So people who are, when you say active, it depends what you mean by active. I talked about bike riding. You can bike for a really long time and there's not much impact happening inside your knee. But as soon as you start running or jogging, boom, 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 it starts impacting in there. So you can be really active and exercise a lot, but it's about choosing, exercises that may be very intense but are low impact. That will cut down on the wear and tear. Partial knee replacements in general last 5 to 10 years shorter in comparison to total knee replacements. So you're looking more at 10 to 15 years as opposed to 15, 20, 25. With the new technology we're using, the robotic surgery technology, we're able to put parts in a more precise alignment. Better alignment slows down wear because the loads are much more evenly distributed. So it may be that these robotic surgeries are going to last a bit longer, but we're going to have to wait, 20 years to get a lot more information about that. The robotic surgery for total knee replacement has been around, about 10 plus years or so. And we're going to have a better idea if we're getting an extra 5 or 10 years out of that in the coming years. So that was a good question as well. Here's another one. I had a severe fall on my knee about 10 years ago. That seems to be the cause of my knee pain now. Can a fall so long ago cause issues so long after? Absolutely. So the slide I had about tread on tires. So if you 10 years ago took your car and scraped the tire against the curb and it rubbed away a lot of the rubber that was on your tire, you may still have some rubber on, so that may not cause a big issue, but 5 years down the line, as things wear out more, that spot where you scraped all those years ago now is the big source of problems. So kind of, if that hopefully makes sense, if you damage something in your knee, maybe you shrink the cartilage at that spot, you make a pothole in the cartilage at that spot. 10 years ago, you may have had enough other cartilage that it, even though there was a divot there, it wasn't so deep. But as the years progress and things wear more and more, that same injury or that same spot becomes the problem spot. That's where now it's a deep pothole because it's worn out further. So we absolutely see people, who prior injuries can lead to knee problems. In general, people will get problems in their knees and joints at an earlier age if they've had multiple injuries to the knee that cause more problems. Here's another question. When you do a surgical procedure to repair bone, like a fracture surgery, I'm assuming, what happens to soft tissue damage in the same area? Do you do any repairs, or is it just left to your body to repair itself? That's a good question. Depends, as it's most things, it depends. Depends on what the soft tissue injury is and depends where it is. In general, I'll try to do soft tissue repairs as well as if I'm doing a fracture surgery for damaged bone. So as an example of that, if somebody breaks their kneecap, when we get in there, we'll often want to do plates or screws or some kind of construct on the kneecap. And some people will pretty significantly tear through their tendons and the ropes that help to move their knee around as part of that as well. And I always spend a lot of time sewing that up as part of the surgery as well. So I do all my hardware work and then I do the soft tissue work. When I'm in there doing a knee replacement, if there's damage to the ligaments, a lot of the ligaments are not necessary or not things you need as part of a knee replacement. There's two that you do need, and that's your MCL and your LCL. And so we'll always look to see if those are intact. If they're not intact, there's different types of knee replacements you can use to take over the function of what those ligaments used to do. So it's always again, it's a depends question. But if we do see injuries to the soft tissues, I'll try to repair those at the same time as doing any kind of fracture surgery. Here's another patient. I have heard aspirin and Voltaren cream is harmful to the kidneys. Is that true? So Voltaren cream does not have aspirin in it, but anti-inflammatories like Voltaren or diclofenac was the other name for that, do cause problems with your kidneys. So Voltaren can cause wear and tear on your kidneys, but it's not from aspirin, it's from the Voltaren. Any anti-inflammatory you use is processed by your kidneys. So ibuprofen, Motrin, diclofenac, Voltaren, celecoxib, meloxicam, whatever you think of. Those all do cause wear and tear on your kidneys. Voltaren in the cream form, in general, out of all of them, is going to have the lowest impact on your kidneys in comparison to the rest. The reason for that is since it's a cream, it's mostly absorbed at the skin and at the site where you put it. Much less goes into your bloodstream and is absorbed by your kidneys. In general, I have lots of patients who use that stuff all the time, and the factor of how long it lasts and what it does can vary person to person. The impact it has on your kidneys has much more to do with how good your kidneys are and what other medications you may be taking. So somebody who's otherwise healthy and has healthy kidneys, you can take those medications pretty regularly. It's not a big deal. If you have a lot of medical issues like diabetes, high blood pressure, things that are also causing damage to your kidneys, when you start to stack multiple kidney damaging things together, that's where people really start to see problems. So that is something that to be thinking about with those kind of medications. So that was a good question as well. Let's see. What is the dosage for ginger, turmeric, and other similar natural remedies that you would recommend? So there's not, from the stuff I've read and seen, I don't have really great guidance on, how many milligrams, how many, that kind of stuff for ginger, turmeric, and that kind of thing. In general, most of the ways you would buy them, the packaging will have some kind of recommended dosage. So if you buy, a bottle of Aswalia, they'll say, oh, take 1 to 2 pills or, something like that. And they've usually packaged it in such a way that they've calculated out what the milligrams is. It's hard to make a general recommendation for, 1 or 2 pills because they package at different levels. So usually whatever bottle you buy will have a recommendation about kind of what they recommend is the optimal dose for those things. Is it safe to have a procedure done given the current state of COVID? That's a great question. So right now, the hospitals are, having lots of COVID patients come in, and staffing has also been a big issue. So they've had, nurses and doctors out with COVID as well. With that going on, basically the hospital has had different times where they've had to shut down elective surgery. So that's happened about 4 or 5 times now at this point, where the hospital has said, we don't have as many beds as we need, or the staffing we need. We're shutting down all emergency cases, and joint replacement, like I do, falls into that category. So I've certainly had people where we got them all set up, they were on the schedule, and then as we got closer to their surgery day, the hospital said, we just don't have room to do that due to the surge in COVID cases. When that happens, we delay the operation, and then as soon as the hospitals are open again, we get people back on the schedule. The way things are set up, we COVID test everybody before they come in to have a surgery, and we make sure that we're doing the surgeries in such a way that people who are there because they're having a knee or hip surgery, they get their surgery done and they stay in an area that is not treating COVID patients. So we don't mix and match. Your neighbor wouldn't be a COVID patient if you were having a surgery in the hospital. The other thing is, now that we're able to do some people in the surgery center, we've had some patients who are really electing to do their surgeries on an outpatient basis in the surgery center to avoid having to worry about COVID cases in the hospital and all of that kind of thing. Obviously, at the surgery center, we don't treat we're not treating any COVID patients there. It's just an outpatient surgery center. But some patients, they're not healthy enough or strong enough to do that. In those cases, we'll wait to see, when the hospitals are running and operational and safe. To be able to do that. So when we have the green light, it is safe to do those procedures in there. As with anything, during the COVID pandemic, there is risks involved with COVID and what's happening right now. That's a risk, whether you do the surgery in a surgery center or in the hospital. You could get COVID during your recovery. So that is something I counsel my patients about, and we talk about when we're thinking about, surgery and the times and all of that as well. Here's another one. Is there harm in waiting if I am having hip or knee pain? So yes and no, and I'll explain what I mean by that. So is there harm in waiting if I'm having hip or knee pain? No, from the perspective of almost all cases, with very rare exceptions, whatever's going on inside your hip or knee is fixable from someone like me. So I tell people, I say, I look at it and I say, you're not losing anything to wait here besides your own time. So I never look at somebody's knee and say, oh, you need to go have a knee replacement as soon as possible. That's really not how this is. It's something where it says, well, what's your pain like? What's your function like? Try some of these non-surgical things. If you feel that your pain is not controlled well enough and you feel like you're losing function, it's worth considering a knee replacement. But the surgery is always going to be there. It's always reconstructible. And because of my background, I do some fairly complicated reconstructions. Even people with, half of their knee missing and part of it's broken and it's 30 degrees sideways and things like that, I can fix knees like that. So, in that case, whatever's going on inside your knee, it's generally fixable. And so that's, from that perspective, you're not losing anything to wait. I can fix it later, whatever's happening later. It's something I'm still capable of fixing. The things you give up is, obviously some people get it done and they say, oh, I wish I'd done that earlier because now I feel so much better. So, your pain and suffering is what you lose. The other thing you lose is some people will let themselves get really debilitated before they want to move forward on a surgery. So I've certainly had patients where, they were walking with nothing, their joints get worse, and now they're using a cane. Their joint gets worse, and now they're using a walker. I've seen some people that wait till they're in a wheelchair before they say, okay, I finally got to get the surgery done. Well, somebody who's getting a knee replacement or hip replacement and they're starting in a wheelchair, their recovery is going to look really different than somebody who walks into my clinic without a cane, may have a lot of pain, and they want to get the surgery done. So how strong you are, what your muscles are, what your activity level's like, that determines a bit on how fast your recovery is. So, I always tell people, if you're starting off with a walker, it's not fair to compare your recovery to your neighbor down the street who's walking with a cane or nothing at all. Because if you're using a walker, your muscles generally aren't as strong as the person who may be walking with no assistance at all. So those are really the harm. But from a standpoint of, I never see anybody and say, oh, well, if you'd only seen me sooner, I could have fixed it, and now it's unfixable. That's basically nothing. That never comes out of my mouth, because whatever's going on in there, I have a way to fix it. It's just, how how long will your recovery be? How complicated will the surgery be? Those are the kind of questions, as opposed to, oh, it can't be fixed anymore, that kind of thing. And I guess the only other caveat to that would be weight gain. As I mentioned, there's a threshold for BMI, body mass index. Above 40 is something we consider to be too high risk for surgery. So if somebody's BMI was really close to 40, like you were 39.99999, something like that, and then, they could do the surgery at that point, they're a candidate. They don't do the operation, they gain a bunch of weight, and now their BMI is 42. Well, now they're no longer a candidate to do the surgery. So if somebody was kind of right on the threshold of their body mass index being too high for surgery, that would be another circumstance where waiting, you could not be a candidate anymore because you gained a lot of weight. So that would be another consideration. I had another question here. What services do you provide? Other services? And I kind of mentioned the hip. I'm a hip and knee specialist. Basically, I treat anything going on with the knee and anything going on with the hip. So those are really my focal points. I work, as I said, at SCOE, the Southern California Orthopedic Institute, and we're all specialists there. So we all, if you have an elbow problem, we have a guy who specializes in elbows. You have a back problem, we have a guy who specializes in back problems. You have a foot and ankle problem, we have a foot and ankle guy. Hand problem, hand guy. Knee problem, we have lots of knee guys. So we have people, we all specialize, we're all fellowship trained. And I have partners who do a lot of the other things that I don't do, but I am a hip and knee specialist. So anything having to do with the hip or knee, I would be your guy. I could take care of those kind of things. See if there's anything else. That may be all of them. Okay, great. Well, I don't see any further questions on there. So I think that's it for all the questions. Thank you so much for everybody for attending. I know I often used to do these in person. It's a little weird to do it on Zoom, but it is great to have everybody coming on here and asking some great questions.
So thank you, everybody. And I want to just, again, thank you all for your attendance. This is recorded, so we will definitely get this out to you. I also would like to just use a friendly reminder. We have some upcoming talks that will also, again, be virtual. Again, March 1st at noon, Dr. Malari, a colorectal specialist, speaking on with a testimonial, as well as we will have a urologist speaking about national kidney health. So at this time, I would like to say thank you, and we will hopefully see you again soon.
All right, have a great day, everybody. Stay safe.
Thank you, Dr. Balch.